Welcome to the medical law and ethics session case discussion series by Cloudphysician Academy. And it's always a pleasure to see the big bosses of Dr. Mani, Ujjwala, Monica, Arun, and a lot of others who work in India and maybe in other countries as well, who have experience to share their knowledge with this particular um, uh, subject, which we don't generally discuss in um, uh, medical schooling, nursing schooling, etc. So this series is, we are doing this in terms of in a way in which we do case discussions. I'll be presenting a case which has been shared with some of the panelists, and we'll start off the discussions. To all the audience out there, please feel free to actually put up your hand and ask questions, discuss during this with share your experiences about certain things. These are real cases which have happened and judgments passed, and relevance to what our clinical practice is, what we need to discuss during this series. So as a start, I'll just start off with the case. I'll just read the case through. I hope all of you have had a chance to actually look, mainly the panelists, at the cases. But this was a case essentially which was which happened in 1995, and it's a verdict from the Supreme Court of India. Some of the names are this is freely available online, and hence the names have been retained as it is in this particular presentation. So we in 95, sometime in August, I think, or July, I would say, there was the appellant, or the person who put the case, was an unmarried woman of age 45 who put a case against a consulting doctor who is known as the respondent and the respondent's assistant. Reading through the case here, just highlights of the case. There may be more in details, but I will go through the highlights. So in May 95, the patient, or the unmarried woman, presented to a clinic. These are the factual descriptions of what happened according to them, undisputed events, and then it goes on to what the case is going to be. Visited the clinic for the clinic and complained of prolonged menstrual bleeding for 9 days. So the respondent examined the patient, advised her to undergo an ultrasound test, which she did undergo, and then after examining the report, there was a discussion with the patient to come back the following day for a laparoscopy for testing of what needs to happen next, and make a confirmative diagnosis, and then go forward with the treatment aspect of it. The following day, the patient went with her mother to the clinic, and there were some consents taken on admission and discharge card. There was a hospital admission and medical treatment consent forms which were signed by the patient, and there was a consent for surgery as well. Some of these consents and the details of that are, and we won't be reading about it here, but there was consent taken. The admission card showed that the admission was for a diagnostic and operative laparoscopy, which would be held on the same day. That is that the patient came to the clinic. So the consent form was actually filled by the doctor's assistant, known as the respondent's assistant, and it was described to be described as the procedure to be undergone by the patient or the appellant as diagnostic and operative laparoscopy, and a laparotomy may be needed next to it. Then the patient went under general anesthesia, had a laparoscopic examination. When in between, during the examination, when the patient was still in theater, the assistant came out of the operation theater and took a consent from the patient's mother, who was waiting outside, to perform a hysterectomy under general anesthesia for ongoing bleeding or a complication which did happen during the process of, I don't think the word complication is mentioned, but for a hysterectomy was taken. Then the patient had a total abdominal hysterectomy as well as a bilateral salpingo-oophorectomy, that is removal of the ovaries and the fallopian tubes. I'm reading it out in detail because many of our audience here may not be in the medical field as well. So then the appellant left the clinic on 15th without paying. That is 5 days later, patient got discharged, but the patient went home without them settling any bills. About 10 days later, there was a complaint lodged by the clinic to the police that that on 15th, the appellant's friend had abused and threatened the respondent, right? That is the respondent is a doctor and appellant is the patient, and that against medical advice, he got the patient discharged without clearing the bill. The patient or the appellant also lodged a complaint telling that on 31st, that is a week later, alleging that negligence and unauthorized removal of reproductive organs occurred during this process with the police. Then the first respondent or the doctor issued a legal notice demanding a settlement of fees of about 39,000 rupees 5 days later, right, for professional services. This went to court, and then it was filed before the commission, and then the patient claimed a compensation of 25 lakh from the doctors or their group for their negligence. Finally, I would actually want to just stop here and just have one question to Dr. Ujjwala. Ujjwala, which see, we know that this did happen about in 1995. We have gone through a lot of processes of changes in the law, changes in the way in which there is knowledge dissemination by doctors, nurses. Possibly, I would say 30, 40 years ago, there was more, the doctor-patient relationship was also quite different compared to what it is today. I just want you to, as a lawyer, as the history or the way in which this has progressed, if you can tell us your thoughts about what would be a big difference in what our people now we need to know.
From this case to now,
from this case, or from generally from the law point of view, is there major things which we need to worry? Because we can come back to the.
Okay, so I mean, just to kind of give a little bit of context, I mean, because I also see that
so basic
people in
it's a huge thing, yes. So the context I want to know is, see, we all work on basic medical ethical principles, which is mainly the beneficence, that is doing good, doing no harm, non-maleficence, autonomy, justice, and things. I suppose that has never changed because it's more than 100 years ago. But legal things in terms of how consenting happens, maybe for consenting, maybe in the way in which we actually talk or think about understanding of the patients is one big aspect where I wanted you to put.
Sure. So I'll just, I mean, to give a little bit of history to, maybe many people who are here today for the first time, 1996 was a fairly milestone year for healthcare professionals as a whole, because that is when doctors or medical professionals came into the purview of consumer law, which they were not. There was specifically a VP Shanta judgment, if I'm not wrong, that completely changed the landscape of how medical negligence is looked at. And I use medical negligence as a broad term, not narrowly. And once medical professionals came into the purview of consumer law, and it became easier for a person to file, go to their, with their problems to consumer court. We saw a huge increase in the volume of cases that went in front of courts. And today, of course, I don't know whether we have the accurate figures, but some people say that maybe there are almost 50 cases filed a day or something. And this is the last I heard. I don't think I can be quoted, but it's a very, very high volume. Some very legitimate concerns that have gone, and some maybe also frivolous concerns that, like any other field. Having said that, I would say that, the whole reason why we even started this series, and it's been a lovely journey, is because I think the key thing is having awareness and understanding of the law. Because the biggest misconception that most medical professionals have is that they feel a sense of that I am being judged unfairly. Many doctors I've heard this from, and it's because many medical professionals assume that the law expects the highest or the best possible care, or the perfect care, almost like a textbook. But that is not the case at all. That's not how the law as a whole looks at what is the expectation. So the first thing is, in the eyes of the law, there are facts. So I think that's where the documentation becomes the most critical piece of information. That is the only source of truth, so to speak. So if I have a starting point, I would say documentation. That's the first place, because when things are over and, a patient has been discharged and, they've gone home and they decide that today they feel something wrong has happened and they want to go to seek justice, the only piece left that they can take is the documentation that's there, that either that is that the patient has access to, or that the hospital and the doctors have access to. So most often I would say even one may not remember the facts of the case as it may have happened, so they have to refer back to the documentation to even know what happened and why a certain decision was taken. I think that even outlining, so that's where I'll take one example, and I don't want to go into a very boring textbook thing where we talk about consent forms. And, big question is, but even in this case, of course, this was a landmark judgment to define consent itself. But many doctors will say consent was taken. But what consent was taken for? What did the patient even understand and know what they were giving consent for? So really the spirit of consent is what the law is looking for, not whether the consent form was signed itself or not. Did the patient and their family even understand what they are giving consent to? Did they have, I think the very word that was used in this case was, the judge said, was there adequate information given to the family to give consent? So really, what I would like to kind of end with is saying that I think the basic understanding of why, how is the law going to look at a case, or how is the judge going to look at a case and understand the sequence of events, and whether the doctor did everything in their capacity, everything was done to the best of their knowledge and extent, right? That's like the gist of what everyone's looking for.
Yeah. No, I mean, that's thank you very much for that, because the spirit of the consent is a very important thing, because it's not only about paper being signed, but the whole process of understanding. And I mean, I would actually like to take the next question to Dr. Mani in continuation with this about, I mean, with your decades of experience in which the consent process, or the way in which the doctor-patient relationship in terms of how much we want to explain to them versus how much they can actually grasp things takes over. What is the major changes you have actually seen over this period of time? It's not only about this case, but in general from that aspect. So
I think the spirit of consent is a very important phrase, right? And that has always been the same, whether 1995 or 2023. And that spirit is not being respected even today, unfortunately. We have got caught in the form, getting a signature. Very often the signature is obtained by a junior doctor or a nurse. not with a direct communication, particularly in a case like this, when they anticipated that something of a surprise could happen. That is why they took consent both for laparoscopy and for laparotomy. If that were the case, they should have spelled out on what circumstances this conversion would take place. Extremely important that we take consent directly from a patient who has retained full capacity, rather than do a hurried job in the midst of a surgery during anesthesia. When it comes to taking out reproductive organs, it may be, in fact, very important to get the patient off the anesthesia and talk, or defer to another moment if it is not a life-threatening. So I do not know under what circumstances a salpingo oophorectomy also had to be done apart from hysterectomy. Now it's very difficult. Hysterectomy may have to be done for bleeding, uncontrollable bleeding, and for which you may have to take a surrogate consent. But salpingo oophorectomy, it's not an emergency procedure. And one ovary or part of the ovary being retained is so very important to be for a woman, right? So I think the sensitivity of what they were doing and the need for consent should not be any different in 1995 or 1985 or 2023. It is all the same. Since consent has been there, whether it was a paternalistic medicine at that time, more equal medicine today, there has never been a time when you could do just to go through the motions of a consent and be protected in law. I don't think that's what the law has prescribed at any time when consent has been in position. So I suspect that the salpingo oophorectomy is a very crucial thing. And if you haven't had prior consent, or it has not been made explicit at the outset that this may have to be resorted to under exceptional circumstances, I think it's a very weak case for the respondent. And any time, any time in history.
It doesn't depend upon which era things are happening, but it's about the whole process. I mean, coming to that question, we may think, I mean, in terms of obviously there would be a huge difference in whether it's paternalistic or not. There would be a huge difference in the way in which understanding of the patient and understanding of the whole process. Because if I think about 95 compared to today, I mean, a surrogate consent is okay in terms of an emergency. It makes common sense, but doing processes apart from that. I mean, if I just ask Monica, who's working in Singapore at this point of time, look, how does consents actually happen if you look at it in the place where you work, for example, about anything?
Yeah. So consent takes place in various ways. So if your patient needs an emergency procedure, and for example, a patient of head injury needs a brain surgery or any kind of operation which needs to be done, for which there's an emergent need, and the reason is that it would be not right to not do the operation, in that sense that it is at risk, it is a life-threatening condition, and the patient is not able to give consent because the patient is critically unwell, unconscious, sick, like, typically ICU patients who sometimes arrive in the ED. At that point, the consent, yes, is taken from the surrogates. And the consent, therefore, ideally, of course, is done in the physical presence rather than on the phone. And it is done with a lot of effort, explaining, one, the reason why that procedure needs to be done. What is the problem if the procedure will not? What is the other option? Is there an option of not doing the procedure? And what are the common problems which can happen intraoperatively? And usually what I see is that, so for an operation, a surgeon would take the consent. The preparation for that consent would be done by the physician, which could be, anybody from ED or ICU. So the person who's doing the procedure himself may not be able to take the consent, like, the senior most does, but a senior enough person. So the person who's doing the consent must understand the implications of the procedure. It can be a medical officer, it can be somebody who's very young, but he must understand that. So that is done in using surrogates only in emergency. For an elective operation, like in this case, you have enough time, first of all. The patient has not come to you in an emergency. So for elective operations, you need to sit down. And what I have seen, surgeons spending almost 45 minutes explaining, the procedure to, especially complex procedures, like, where either outcomes are guarded because of patients' comorbidities and they're expecting things to go wrong, or the surgical is such that things may go wrong, or like in this case where you don't know what you're going to face. You have a diagnosis of endometriosis, there is a possibility of needing to do few things intra-op. All those options are discussed, options of procedures and options of not doing the procedure. Is there an option, and what is that option, and what is the implication of the procedure acutely? And like in this case, as it has been said in this case, removal of ovaries, which will lead to hormonal effects, need for hormonal replacement therapies, right? So it has a big long-term impact on the patient. So one is that who takes the consent, as Dr. Mani had said, somebody who really understands the implications of procedure, and usually how the procedure is done, why is it being done, who takes, from whom do you take the consent? Definitely the patient himself, if he has the capacity. In rare circumstances, in very rare circumstances, for elective procedures, if the patient does not have capacity, like for a patient who's suffering from mental illness, dementia, there a surrogate takes the priority, and sometimes the guardianship rule may come into play where you don't have a next of kin. So otherwise, in 99% of the cases, in elective operations, the person himself gives a consent. Now, I see this a lot in Asia, that patients, like elderly patients, rely a lot on their families. So practically, sometimes they may say that, look, I don't fully understand. Can you explain it to my son? And that's okay. The consent is being then given with assurance to the family. So, and that's very much like India as well. A lot of it means explaining the procedure also to the family member. But I think the person who's undergoing the procedure holds the authority, isn't it? Like, in the sense, unless he himself says that I give this this opportunity of giving the consent to my son or daughter, or anybody else, I mean, barring that, all the explanation be done to the patient himself. So yes, so unless you declare the patient as bearing not having capacity, like a patient who's confused in ICU. For ICU patients, it's a bit different because some of them might be delirious or may have septic encephalopathy. In that case, yes, the surrogate, that is the next of kin, becomes obviously the representative of the patient.
Yeah. No, thank you, Monica. I mean, I don't see that there should be a huge difference in the way in which any country or any place should actually do things in terms of consenting. Dr. Arun, are you around? Dr. Arun, great. I would like to actually take your view. I mean, being an intensivist and going through this process of consenting in the intensive care, most of our patients are going to be critically ill. They may not be able to give a direct consent. Yes, there is a next of kin. Would you actually look or see certain places where you can still delay things for a period of time in intensive care situations when almost everything is considered to be emergency, or we should be careful, or should we be careful even at that time in terms of how we do procedures or what we do?
In my setting, I think, as you rightly said, most of the patients are sick. So what we do is, most of the times, we involve the family. Our consent form has a section which says, if a surrogate is being involved for taking consent, give a reason. So most of the times we would mention that the patient is sick and unable to give consent. So that is something which is documented in every consent form. We do have a pre-printed form with very limited scope for writing things down. But even then, what we try to do is we try to give as much information as possible. What we essentially do is give a reason for the intervention. Let's say if I am supposed to put a central line, so I'll give an indication of why I'm thinking about putting a central line. If there's a deviation, if there is any kind of deviation of procedure, when I say deviation, let's say a patient has a high INR and he still requires a central line. So I would mention that deviation. And if I'm, let's say, using, giving plasma prior to putting that thing, so I would write down that the central line is being inserted after giving FFPs and after correction of INR. I would always mention, so I'm just taking that example just to show you the amount of the documentation that we do. So I would always write down that the central line is being inserted under ultrasound guidance. We do explain the side effects to the family. One thing which I've learned from some of the consents which I've seen from certain hospitals is they mostly write down any other complication which may arise during the procedure. So that's a statement that I've seen being written in certain consents, because see, you can write down bleeding, you can write down infection, you can write down vascular injury, you can write down pneumothorax, but you can write down arrhythmias, but there could be some other complications too. So we do write down that any other complication which may arise during the procedure. We always make sure to document that there are no so our consent form has a column which says, is there an alternative to the proposed procedure? So we always write down, for example, so if I take the example of a central line, we would write down that the patient already has multiple venous lines being inserted. He or she has limited venous access, and he's on multiple infusions. So essentially, we do a significant amount of documentation for the indication for the procedure, the complications that we may see. There are no alternatives. The surrogates are important because the patient is sick. So yes, we do all these things whenever we take a consent. In case we find that the patient is a sick patient where the outcomes may be guarded, we even have a counter documentation in our progress notes where we document the acceptance or denial for the consent which has been taken. So this is how we see things in the critical care setting.
I mean, that's fantastic, because there is so much of details which are, even though there is not much space in a consent form, which is presumably done by your organization itself or made by your organization. I just want to bring in one question in that to maybe Ujjwala and then Dr. Mani again. Do we have an ability in the country from a legal point of view to use standard formats along with enough documentation in written for a consent? Or is it okay to do it, or should it be much different in any way? One is opinion, and what is the legal basis of that? Pre-printed forms is what I'm trying to say.
Sorry, your question is it okay to use pre-printed forms?
Yeah, someone else has also asked the same question.
Right. I mean, this is a $1 million question that we're all debating. I mean, there have been, so there is two answers. I mean, what I'm going to be telling is actually, it's my personal opinion, because I don't think there's a definitive statement made by any court saying that pre-printed forms are not valid.
Sorry, I'm just muting you, Dr. Arun.
Sure. So I don't think pre-printed consent forms have been made invalid in the eyes of the law completely. But having said that, I think this cannot be a standard answer, because pre-printed consent forms sometimes are very, very widely, I mean, I would say not widely, sorry, written with every possible consequence mentioned, right? So it's almost like by signing that, a patient or their family are essentially agreeing to anything and everything under the sun, which in my view, would be completely, not accepted by any court. They would not accept that there's this completely, overarching consent form that's a consent for everything. I think largely consent forms have to be specific. I do not think you can have a single blanket consent form for all treatment. What do I mean by that? For example, procedures that need to have their own consent form. Each procedure has its own risks and its own set of complications that can happen, which need to be explicitly mentioned in the consent form. So a pre-printed consent form, to answer, in a concise manner, a pre-printed consent form is acceptable if it is still specific, if it is clear what the patient is giving consent for, and in the course of that procedure, if there can be complications that can happen, and those need to be explicitly mentioned, and in that case it is acceptable.
Yeah.
I think Dr. Mani,
Yeah, I mean, Dr. Mani, do you want to tell anything, or there is a question which
I want to say that just a generic consent form for one glove to fit everything is a mistake. And that is certainly not the spirit of consent. Spirit of consent is for what is germane to that particular case. So you see, I can't put in all the conversation into a consent form. So the conversations go on in a family meeting where we bring it up. We want to put a CRRT, for instance, a dialysis, why we are doing it, what are the pros and cons, that we may mention in the family conferencing sheet or in the case notes itself. And having gone through that, you have given consent. So the issue is we can't possibly cover for everything. And that is not the spirit of the law either. You must cover at least the essentials, right? I think Ujjwala, has to bear this out. I think the essentials, you can't cover everything. You can't say, well, everything can go well, or somebody may die on the table, right? That is very alarming to hear, for one thing. Huh? It says there is a risk on driving, but you can just crash and kill 15 people. I mean, that's not. See, you can't cover everything. Huh? And even an insurance company will not cover everything.
Yeah.
No MOU will cover everything. So it should make common sense. And I don't think anybody is looking for that exhaustive consent form.
Yeah.
It's silly to make an exhaustive consent form which nobody will read, including the consent taker, right? And you don't even know what the content is. You just sign, and you sign away everything, every possibility of legal liability. That's not possible.
Yeah.
So we cover the essential, what are common, and you may say, yes, sometimes unforeseen things happen, that you can leave it at that. So I think it has to be customized. It has to be customized to the patient, to the situation, and to the procedure. You can't have a blanket consent form. You may have as a addition to all the counseling you've done.
Absolutely. I mean,
You can't fit in the counseling process into the form. That doesn't make sense.
Correct.
Dr. Shashi, can I
Yeah.
just add to what Dr. Mani said? There are basically a few building blocks, and today we don't call it pure consent. Actually, it's referred to as informed consent is now the term that is being used. And informed consent has a few building blocks, starting with competence. That is the competence of the person who is asking for consent. And so that's the first thing that they will look at. The second thing is disclosure, whether the information that is disclosed to the patient or and the family, whether it was sufficient, whether it was right, whether it was enough. The third thing was understanding on the side of the family, the patient and the family. So did they even understand the information that was given to them? The fourth part is the voluntariness with which they gave the consent. Was it taken? Did they even have a choice in giving it? Was it voluntarily taken? And finally, was consent given? So these are actually the building blocks of consent. So really, when you look at a form or look at the fact that was informed consent taken, these are the factors that a court would look at, just to give some context.
No, absolutely. I mean, informed consent. And Dr. Arun, you had your hand raised for comment. You're muted yourself. Sorry, we had to mute you.
Sure. Thank you so much. So the entire controversy about the printed form, I think we saw recently about an year or two ago, where there was a judgment, RG urology stone versus, I think it was a National Commission decision, where they had imposed a fine of, they said there was no negligence on the part of the doctors, but since the pre-printed consent forms were used, so they put a fine of about 10 lakhs on the RG urology stone hospital. So this judgment was heavily criticized both in the medical circles as well as the legal circles. I think we need to accept one thing. Nobody reads the pre-printed forms. We all need to agree on that. It's almost similar to signing on a loan agreement. We never go through that aspect, and even if we'll try to go through, we'll not understand anything, and we'll at the end of the day they'll take signatures wherever they expect us to sign. The essence of an informed consent is what is discussed has to be written somewhere, and that needs to be available in case things go wrong. I think the judiciary would probably look at the fact that whether the discussion did happen or did not happen, whether the family was made to understand. They would expect that the discussion happened in such a way that it was in a very simple language. So when we take our consents, we try to write down it use the medical language is used as limited as possible. Again, if I have to take example of a central line insertion, I would say we write down insertion of a large cannula in a neck vein. So we try to be as simple as possible with an aim that the family is able to understand what is being done. So that is something which I would probably tell about the disclosure part.
Yeah. No, thank you, Dr. Arun, because at the end of the day, as Ujjwala mentions, there must, even if it is there anything pre-printed, you must have certain amounts of building blocks into it, where who is taking the consent, and as Monica was mentioning, it happens across the world. There is a question about, Dr. Rashmi is asked about standardized protocol for consent, and we have probably got that answer in terms of making it very personalized rather than a standardized protocol. And there is an important thing which he has brought up in terms of is it only the written thing, or what is the value or what is the importance of using technology at this point of time, audiovisual aids to do things? And let us keep aside the fact that the feasibility of doing that, the cost involved in this one, storing, all that is another big thing. But just is it done in your place, Dr. Mani, or anywhere for any particular process? And then I'll come to Ujjwala about how serious, and what about Monica later.
Sometimes if a consent is for an exceptionally difficult situation, or has certain nuances or ambiguities, like organ donation, you take a video consent, right, for a donor.
Mm-hmm.
However, routinely for using video and all that, I think they are neither necessary nor practical.
Yeah.
If you have a particularly difficult dilemmas to deal with, and for which you've had a conversation, you may record it. That is all right, but of course, with prior knowledge of both parties that is being recorded, right? Mm-hmm. That is all. There is a consent for recording anything also. We must remember we can't just record without knowledge of it. So we must remember that, and that so that process should be transparent. The process should be simple and replicable. You can't have extraordinary ways of doing things to cover everything. That's not required. You can't do it on a daily basis.
Yeah. And do you agree with that part of it, Ujjwala, that every audiovisual, the legal basis of that, and are courts going to accept it in small things?
It's a tough one, Dr. Shashi. The courts accepting it. See, the consent forms, the one advantage of pre-printed consent forms is that there's a prescribed format, so you will go through it. Unfortunately, when you're doing, let's say, like a audio video, a recording, which, like sir said, you have to take consent first for that prior to actually even taking consent. So actually, in a way, defeats the purpose, because you need another consent for this consent. But having said that, the chances of missing things. For example, the basic parts of name, MRN number, these are things which again will pose issues. Or did the doctor explain? Then it might go back to the words that the doctor used. It might end up being a lot, causing maybe even more, I would say, confusion than sometimes, helping solve things. So I would say that being more smart about using the consent forms, and like Sir said, actually truly being transparent and writing and documenting that along with saying what you have explained to the patient would be sufficient. Having also, the more obstacles we put in the way, the less gets done. So if you're going to make it even more difficult for doctors to take, already there's a time constraint, there's a resource constraint in taking consent, right? Things are happening so fast. So, again, if they have to go into a room, get the audio visual, setup ready, then, take consent for that, I feel it's going to actually hinder the process. Unless, of course, softwares and technology also moves much more forward. And then, I mean, it's possible, but we're not there yet.
Yeah, and fortunately or unfortunately, I don't know, we have so many audiovisual recording processes, the WhatsApps, whatever the social media, and in fact, I want to go to the Monica next, but I just want to put in the fintech. I just read an article that an Australian man, a farmer, was fined. I mean, he was asked to pay a bill of $38,000 to a Canadian man because in a text message conversation he had put a hands up or a thumbs up as an emoji, and this essentially became consent to, in the Canadian law, that the transactional thing has happened and he had to pay up this money. So I hope we never come to that situation in anywhere, because health is completely different from financial transactions. But Monica, I mean, with this technology coming up, do you actually think consenting and utilization, there is a role in utilization of technology in the resourceful places, or even in our places, apart from what Ujjwala and Dr. Mani has actually mentioned?
I mean, so to me, currently, what we do is, when families are not available and a procedure needs to be done, like in the middle of the night, right? A procedure needs to be done and it is emergent or it is semi-emergent, let's say. We do the information sharing on the phone. We don't record that conversation. And we do a double consultant signature on the consent form. So the consent is being done with the faith that this procedure is required to save the life of the patient, and full transparent information sharing as much as possible has been done on the phone, since relatives have refused to come to the hospital at night. So first is, physically, when you talk to people, it's always the best. But your question is different. Your question was, can we use the technology to record it? And would you do that routinely, or would you do that in exceptional circumstances? Is that your question?
Not only that, but would there be a role mainly in terms of, I was getting to, you already answered that question, that there could be a role where you don't have the physical presence, but you can use a little bit of technology and then ensure that there is enough explicit explanation to the surrogate, I would say, more than the patient itself. Or what we have probably gone through during the COVID times, utilization of some, because we are potentially, healthcare is doing that in the faith of, in a good faith for the patient itself.
Yes. I just want to say that this act or this belief, I just want to re-emphasize what Ujjwala and Dr. Mani have always stated, that you want to record every conversation. This is a relationship based on trust. So if you start to record everything, like, you are becoming distrustful now as a party, right? Now, and that's not just a good start to a relationship of trust. So we want to re-emphasize that, and yes, there are legal implications, and the world is bad. I agree, people are bad. You might be very, open and transparent, but for that, I feel a good, clearly written note, either on paper or on EMR, is good. Now, if you have experienced families and you don't have EMR in your hospitals, the practical thing to do is, when you've written a nice legible note, you can at least take a photograph of that patient's details for your own record. So, only in the circumstance, not for every patient, if you have experienced conflict with the family. And you've done your best, and this is for future, so that if somebody files a case, you at least know what file to take out. I mean, if you have EMR in your hospital, that's perfect then. You can trace back. So I still believe documentation, as Ujjwala and Dr. Mani have said, you start recording, it's just not a good feeling. I don't still feel that that's the way we should go. The opposite is happening, and we feel like, families will come and say, can we record this conversation? And we let them record, not routinely, but we let them record for relatives who are not, who are far away. So giving them the benefit. So we let them record, but if they are physically there in Singapore, we encourage them to come to the hospital. So, because we also feel that when this person is recording, what you are understanding on the other end is, I can't see your expressions, you can't see my expressions. So it's not a very good conversation. So yeah, so I would say technology can help when distance is a problem. You have a relative or a son or a daughter sitting in US, you want to update them, you want to take consent from them, yeah, but are you going to record that conversation? I'm not sure that's the standard way. Yeah, I would agree with that. Yeah.
No, I mean, that actually brings to future. I just want to complete this next page, which talks about what happened. And the patient essentially alleged that the respondent was negligent in treating her, and the radical surgery in which uterus, ovaries, fallopian tubes were removed without consent when she was under general anesthesia was unlawful, unauthorized. I think we got this point from our discussions in the last 45 minutes that is probably taking things overboard, and she suffered premature menopause, necessitating prolonged medical treatment, HRT, and making it vulnerable to many other health problems in the future. And essentially, the compensation was claimed for a number of things. When we talk about the future in the same point, and with a couple of questions by Dr. Rashmi and Kaul, I just want to bring in two things. One is, see, when we are treating with vulnerable patients or patients who cannot give consent because of any reason, such as an acute deterioration in intensive care, there has been a difference in the way in which the surrogates actually can understand. Dr. Mani, or we'll start off with Dr. Mani and then Dr. Arun, about would you actually look into the capacity or the ability for the families to understand if there has to be a change in the way in which we're going to do things for patients?
See, surrogate, Shashi, can't act on his or her own behalf. By definition, surrogate only stands in for the patient, which means that the patient's value system and preferences will be faithfully represented by the surrogate. Otherwise, here, the surrogate has had no chance to discuss with the patient prior, what her opinions are about getting married, or, having a child, or, what are her views about, preventing the future risks of ovarian malignancy, and weighed against, the side effects of hormonal replacement. So all this, the mother has had no chance to discuss whatsoever. So she has acted on her own behalf. So I don't regard this surrogate as a true representation of the patient's will. So I think here the autonomy has been violated.
Yes.
Right? In a case like this, I would say, I would have thought the same even in 1994, I think, looking back. Okay. So I think this is not a new phenomenon.
Yeah.
This basic respect for the human body and values has always existed. It has got nuance now, a little bit. Awareness and nuancement has taken place, and in shared decision making, it is playing a much more prominent role. But however, these were basics ever. You cannot remove reproductive organs without the direct consent or the consent of a surrogate who has had an opportunity to understand, grasp what the patient might have wanted.
Yeah, and Dr. Arun, I mean, in terms of surrogacy in intensive cares, as Dr. Mani was mentioning, in the concept of surrogacy is what the surrogate actually thinks, and not with a complete understanding of what the patient would essentially want, with the autonomy of the patient. This is always a big challenge in intensive cares. We sometimes make it. We try to think that the surrogate is acting on the best interest of the. What do you have any comments upon this particular aspect of surrogacy from clinical practice? You're still muted, Doctor.
So I'm sorry. I think it's a difficult question. Even from the fact that the question that you asked was, are we actually looking at assessing the competence of the surrogate when we? And I don't think we can actually do that. If the patient or the surrogate has to turn back and say that they did not understand, they can always say that. Uh, what is important is the essence of the discussion that we've documented, which is going to help us. If it is done in a simple language, if the communication was proper, if the documentation was adequate, and if taken the consent of a witness also, let's say an additional witness from the family who has been a part of signing the document, I believe that we would be safe in that situation in case there's an allegation of negligence.
Yeah. Yeah, no, I mean that actually sums up a lot of things in terms of how we look at a surrogate. But I mean, for certain things like transplants, Ujjwala, kidney transplants, for example, there is so much of legal basis and of finding who this surrogate is or who is this donor, and that's a huge process. You can almost never equalize that to general clinical management of patients in a thing. Would you actually suggest anything to the audience here from how they look at surrogacy from a legal point of view? Any specific points which you can bring out?
Honestly, it's a tough question, because I feel doctors are, many times don't have any other choice but to take consent, and they're operating with very little information. So while I think, I would say from a legal perspective, like specifically like in this case, avoid things that doesn't need to be done, that are not time sensitive. If it can wait for the patient's consent, then ideally that would be the right time to do it. Only limit yourself to what would be as almost like an emergency requirement, what needs to be done. And the second part is, while we're taking consent, I think also recording who and why it's being taken from, that would become very critical, because I think no one can comment on who is the person, but that the only person available is X, Y, or Z, and they've come with this patient, and this is the relation to the patient, etc. But documenting just that would be very critical. Absolutely. I would say also that while taking, I think doctors are probably the best judge in terms of taking very serious decisions, as far as, like in this case, let's say the reproductive organs. It would be a lot wiser to avoid doing it altogether, rather than trying to go ahead and finishing it off in one shot. There are many other cases for informed consent where it was judged that it was not required. So I think procedures need to only be done if they're really critical or life-saving.
Yeah, no, that's good. Thank you for that, and for these specific points. I just want to. I mean, we have another 3 or 4 minutes here, and there is a comment by one of the audience here that consent is for safety of a doctor and not for a patient. I have a little bit of concerns about this, because at the end of the day, consent is taken for the patient to understand the whole process, and then it is an open discussion with the patient. I just want all of you to give a couple of lines about what your opinion is about this particular comment, and how much are we as clinicians or need to be worried about this? May I start?
Sashi, I won't call it a consent for the safety of anybody. Okay, it is not covering up legally. That is not the spirit of consent. Consent is to ensure that there is a respect and there is clarity of understanding between the doctor and the patient, and it is mutually clear why a particular procedure or surgery is being done. That's what it is. It's recording it, documenting it. It is for safety of all, not just safety of all. It is the right thing to do, not just legally but morally as well. Yeah.
No, that's great. Monica, you had a comment on this?
Yeah, I just want to say what Dr. Mani said again. It is good clinical practice. You are going to take out something, do something to another human being. Are you not going to explain it? Why you're doing it? What is the implication? Is this how we're going to treat another human being? And yes, of course, it has legal implications because people are not following it. If you don't follow it, policing has to be done. So either you do good behavior, it's like, with children. If they don't behave well, you got to get some rules in. But it is not, I would completely disagree with that statement. That statement is not good clinician behavior, right? So it is not for the safety. It is just good practice. That's how you work as a doctor. You explain and you document.
Yeah. Ujjwala, your comment on this?
The statement that was made is actually very much in line with how many doctors feel. So I don't hold it against him, but I think that safety can only come with knowledge. You're safe when you're operating, when you understand the law and when you understand medical legal implications. Only then you are safe. I don't think any consent form or any for that matter, documentation itself is going to save anybody or, protect anybody for that matter. I think understanding why, and like Sir said, the spirit of the consent is really more important than the consent form itself. Even a pure handwritten form might end up being much more useful and powerful in a court of law than a pre-printed, well thought through, legally, vetted by lawyers, etc. consent form, because it's the spirit of whether that consent was taken correctly and understood by the patient and given voluntarily that matters. So really, that's where safety lies, I would say, in understanding the full knowledge of why we're doing what we're doing.
Excellent, and I mean, the spirit has had a lot of the spirit of consent has a lot of discussion during this particular session. I'll complete off by this last question here, which talks about what if the patient surrogate doesn't consent for a procedure and which is life-saving. I'm sure all of you and maybe Ujjwala also will accept that a procedure which is life-saving is not something which can be guaranteed to anyone, and whether it's court of law or whether it's the basic principles of doing good, the beneficence actually comes through that where you can do the procedure despite I don't know whether you if it's a surrogate giving a consent for not doing a life-saving procedure, doctors may be able to overrule it if they are trying to you don't have the time, first of all, but overruling is that something which can be done. So for example, if there's someone dying and telling don't do CPR just because in a young person may not be the right way to go, is what is that something you can accept?
So the fact that
my legal understanding, my legal understanding is there are no exceptions made for consent. Okay? That if it's an emergency, you cannot decline. It's not so. But if the surrogate is doing it, okay, declining, sometimes the best interest argument comes in, right? If you suspect that the surrogate is not truly representing the patient or patient's interests, then you would have to take a best interest solution, which is not unilateral, but having a collegiate decision, two or more doctors taking a decision and also clearly stating why they think the surrogate's stand is not in the best interest of the patient.
Mm.
And then it is okay. But if the patient can refuse, right, it's fully compos mentis. You have no right on the basis of saving his life to impose upon the whatever judgment it is. It could be right or wrong. It doesn't make an exception.
Yeah.
See, the refusal of consent makes no exception. It may be to your detriment. In fact, it says very clearly, even if it is to one's detriment, you may refuse. Right? But surrogate thing is different. You have to make a call, take a call, whether it is in the interest of the patient or not. And if so, you have to explain why you have overruled it.
No, I agree with that. I mean, it's more about giving autonomy if the patient is able to do it, and doing good if the patient is, if it's through a surrogate by itself. I mean, that was a very enlightening session, all of you. Thank you very much. And if I just put it into 2 lines, the spirit of consent, which is a complete and an informed consent with all the building blocks put in place as much as possible, and depending upon how serious and how life-saving or non-life-saving, non-emergent procedures are, is what we need to essentially do.
Shashi, you must tell us the court judgment.
The court.
What was the judgment eventually?
So, Dr. I mean, Ujjwala, do you want to?
The doctor
maybe
was
a
found
better
guilty
way
of medical negligence.
So did it go against the doctor?
Yes, the
Yes,
doctor was
yes.
held liable for malpractice. It actually went all the way to the Supreme Court. I think the final judgment came out in 2008.
So,
what was the eventual compensation, and what was the comments of the judges?
I don't remember the compensations, but what I do remember was the doctor should have, would have to seek consent before the treatment, and that how they defined treatment was including surgery. And they also said that, basically that's where the definition, the whole, what I was giving you, the building blocks, which today now, that's why this has become a landmark judgment for informed consent. So they gave these building blocks in this particular case for consent. So that's where they defined disclosure, adequate information, capacity and competence to give consent, and the fact that the consent itself should be voluntary. So they should know what he or she is consenting to. So this is a very famous, as known as the Samira Kohli case around informed consent.
Lovely, what a
I
case.
think the full compensation of 25 lakhs was done, as well as the other parts of compensation was whatever was claimed, and with 10% interest from the time when the respondent is not able to pay until the court judgment that did happen. That was the total compensation, but it went against the doctor. And I mean, this is very clear from this whole thing that removing ovaries probably is not a life-saving procedure here. No.
So formal signing of a consent is no protection.
No.
Okay, let's understand that. There is no short stepping the spirit.
True.
Absolutely.
No shortcuts, sorry.
No shortcuts. It's not for the safety of the doctor. It is for the patient, complete understanding, inform. And yes, I think the other comments here about informed consent, disclosure, free voluntary decision making, and competence are all correct. So a fantastic session. Thank you all for joining, and thank you all participants for having some discussion during this session.
Thank you, Shashi, for bringing up this wonderful case, and Ujjwala, Monica, and Arun for a very lively session, and Shashi, of course, the Sutradhar, Yeah. Thank you. Thank you.
Thank you all for joining.
Thank you, everyone. Thank you.
So we'll keep doing this every month. Please do join. Thank you.